Welcome to this USMLE Step 2 CK review on dyspnea test-taking strategies. This video is designed to help you recognize common question patterns and apply clinical reasoning efficiently on exam day. Remember, the goal is not to memorize every detail, but to recognize the patterns that USMLE examiners love to test. This session focuses on 3 key skills: recognizing high-yield question stems, differentiating acute versus chronic presentations, and mastering the next best step format. Before watching, make sure you've reviewed the basic pathophysiology in first aid and pathoma. This video builds on that foundation by teaching you how to apply that knowledge strategically. The acute versus chronic distinction is often the first branch point in your clinical reasoning. When you see time descriptors in the stem, immediately categorize the presentation. Acute presentations like sudden onset or minutes ago should trigger your emergency differential, PE, pneumothorax, MI, anaphylaxis. Chronic presentations like progressive over months point to COPD, chronic heart failure, or interstitial lung disease. This initial categorization narrows your differential before you even read the answer choices. Physical exam findings are gold on Step 2. The examiners expect you to know which findings cluster together. Cardiac dyspnea classically presents with orthopnea, PND, JVD, and peripheral edema. When you see 3 or more cardiac findings, heart failure should top your differential. Pulmonary dyspnea presents with pleuritic pain, cough, wheezing, and often unilateral findings. A smoking history with hypoxia but clear cardiac exam strongly suggests a primary pulmonary process. Let's look at classic stem patterns. For PE, watch for risk factors: post-op status, immobilization, recent travel, cancer history. The classic triad is sudden dyspnea, pleuritic chest pain, and tachycardia with clear lungs. Heart failure stems emphasize orthopnea, sleeping on pillows, PND, and bilateral findings. COPD stems emphasize smoking history, barrel chest, and obstructive spirometry patterns. Recognizing these patterns quickly saves precious time on exam day. Read this question carefully. A post-op patient with sudden onset, pleuritic chest pain, tachycardia, hypoxia, and clear lungs. This is a classic high-probability PE presentation. Take a moment to think through what you would choose before moving to the answer slide. Let's break this down systematically. Step 1. The pattern screams PE. Post-op patient, sudden onset, pleuritic pain, hypoxia with clear lungs. Step 2. This is a high-probability patient. D-dimer is only useful for ruling out PE in low-probability patients. Using it here wastes time. Step 3. Chest X-ray is nonspecific and delays diagnosis. VQ scan is second line, typically reserved for patients with contrast allergies. CTPA is the definitive imaging test for high-probability PE. The answer is C. This question tests a different skill. Reading the question, stem carefully. Notice it asks about guiding long-term management, not confirming the diagnosis. The clinical picture clearly shows heart failure. Orthopnea, JVD, crackles, edema. What test tells you how to treat? BNP confirms heart failure, but doesn't guide treatment selection. Chest X-ray shows congestion, but doesn't differentiate HFrEF from HFpEF. ECG might show prior MI, but doesn't assess function. Echocardiogram is the answer because it shows ejection fraction, distinguishes reduced versus preserved EF, and identifies wall motion abnormalities. This directly determines which medications are indicated. Always read what the question is actually asking. Heart failure treatment is heavily tested. For acute decompensation, remember LMNOP, Lasix, loop diuretics, morphine, nitrates, oxygen, position, sitting upright. For chronic HFrEF, know the 4 pillars that reduce mortality: RNE or ACE-I, evidence-based beta blocker, MRA, like spironolactone, and SGLT2 inhibitor. The exam frequently asks which medications improve survival. All 4 pillars do. Another classic pattern question: heavy smoking history, barrel chest, prolonged expiration, productive cough. This is textbook COPD. The question asks what slows disease progression, not what treats symptoms. Take a moment to consider the options. This tests an important distinction. Bronchodilators, both short and long-acting, improve symptoms and reduce exacerbations, but do not slow the decline in lung function. Inhaled corticosteroids reduce exacerbations in certain patients, but don't slow progression. Pulmonary rehab improves quality of life and exercise tolerance. Only smoking cessation has been proven to slow the rate of FEV1 decline. The answer is D. This is extremely high yield. Oxygen therapy and mortality is a favorite exam topic. Know the specific thresholds. SpO2, 188%, or PaO2, by 55 mmHg at rest, qualifies a patient for long-term oxygen therapy with mortality benefit. The exam may give you exact numbers and ask if the patient qualifies. Also know that nocturnal oxygen for isolated sleep desaturation and ambulatory oxygen for exertional desaturation have not been shown to improve survival. To wrap up, focus on pattern recognition, read questions carefully to understand what's being asked, and know the key management decision points. Visit roadmap2residency.com for personalized tutoring and residency advising. Review the dyspnea chapters in first aid and do practice questions focusing on the decision points we discussed. Good luck on your exam.